Now, we mentioned earlier the heart's function is to pump as venous return. If the heart fails to pump as venous return, by definition, this is heart failure. But some texts will also say, if it pumps as venous return, but only at high back pressures, this is also considered heart failure. But in a steady state, venous return equals cardiac output. Now, we're going to consider two different types of failure. The first is the most important. This is a systolic failure, creating a systolic dysfunction. And we stated earlier that systolic failure is a problem with contractility. This would include any condition in which there's reduced ventricular emptying at a given preload. This would include, again, a problem with ventricular contractility, but some texts would also say excessive afterload. Now, if you have a problem with contractility, in response to this problem with contractility, there be an increase in sympathetic activity of the myocardium to return performance towards normal. If you have incomplete sympathetic compensation, this would be expressed as a reduced ejection fraction, and a reduced ejection fraction is a characteristic of systolic dysfunction. Just repeat that. If there is a systolic dysfunction, in general, it's a problem with contractility, and there will be a reduced ejection fraction. Now, what are you going to expect to see in terms of the pressure volume loop? If you have a systolic failure, a problem with contractility, I expect a decrease in performance, so left ventricular systolic pressure should be depressed. In addition, I expect an increase in preload. Because you have a decreased performance with an increase in preload, that should tell you a systolic failure. Now, as the failure progresses, you have a further deterioration in systolic performance and an increase in preload, and the loop shifts to the right. Because the loop shifts to the right, then the heart is enlarging. But notice the diastolic curve is not changed significantly. Because the diastolic curve is not changed significantly, then it tells you there is no diastolic dysfunction. In addition, we mentioned it earlier again, the increased preload does represent a partial compensation to the decrease in contractility. But the increased preload means pressure is transmitted to the pulmonary circuit, vessel enlargement will ensue. Now, as long as you're in the compliant range, there is a minimal increase in pulmonary venous pressure. But once pressure increases to the point the vessel becomes stiff, then pressure is transmitted significantly upstream, capillary pressures increase, and it causes pulmonary congestion. In addition to an increase in preload that help compensates in a systolic failure, there are additional compensations. We already mentioned there's an increase in sympathetic activity, which is part of the compensation. This will attempt to increase contractility and return that parameter towards normal. You'll also get an increase in TPR that redistributes blood flow to the vital organs, and you'll get an increase in heart rate. In addition, the renin-angiotensin-aldosterone system will be activated not just because you have a decrease in blood pressure entering the kidney, but you'll also have a decrease in the delivery of sodium chloride to the macula densa, and you'll have increased beta receptor activity that all contribute to activating the system. But this will be all put together when we get to the endocrine system. Now, angiotensin II will promote a vasoconstriction, but we'll mention later that the renin-angiotensin-aldosterone system is mainly a volume regulating system. When blood pressure drops, this system is always activated, and you keep retaining sodium in water until blood pressure returns to normal then. So this system will keep retaining sodium in water until blood pressure returns to normal. Now, ADH is also elevated in systolic failure, and ADH is trying to compensate by retaining fluid. Now, we'll talk more about this when we get to the endocrinology section. Now, these compensatory mechanisms that we just talked about help initially, but they tend to become detrimental long term. An increase in total peripheral resistance increases afterload and increases the pressure work of the heart. And you should remember, an increase in the pressure work of the heart is very demanding on that ventricle, and long term, this is a real negative with a systolic failure. In addition, an increased heart rate also increases the metabolic demands of the myocardium. And the increased sympathetic activity that causes the increased heart rate and contractility has an oxygen wasting effect That will tend to decrease the utilization efficiency of oxygen. And aldosterone, when you activate the renin-angiotensin-aldosterone system, does promote ventricular remodeling. It does cause increase in fibrosis. Now finally here, we should consider natriuretic peptides. Now natriuretic peptides are considered beneficial to the consequences of systolic failure because they promote sodium and water loss by the kidney. But even though they promote these effects, they never override the renin-angiotensin-aldosterone system. Natriuretic peptides can antagonize the system, but they never override the system. So when you activate the renin-angiotensin-aldosterone system, you keep retaining sodium and water regardless of the natriuretic peptides. Now, atrial natriuretic peptide is found throughout the heart, but mainly in the right atrium. It's released in response to stress. It is released in response to a volume overload on the venous side of the circulation. Now, brain natriuretic peptide was discovered in the porcine brain, but it is also found in the ventricular muscle. Under normal conditions, very little is present, but if you have a stress to that myocardium, BNP increases and it's released into the circulation. Now, the main point here is that ANP is released mainly due to acute stress, but BNP, brain natriuretic peptide, is released in response to chronic myocardial stress. So in systolic failure, then, this compound is released into the circulation and it correlates with the severity of ventricular systolic dysfunction. That's a very important point to remember. Okay, BNP is a biomarker for the magnitude of systolic failure. Now, we have a very complicated graph to deal with. We're now using cardiac function curves and vascular function curves to explain the consequences of low output heart failure. Now, on the x-axis, we do have an index of preload, and in this case, we have atrial pressure. The y-axis is an index of systolic performance of the ventricle. Now, we're looking at cardiac output here, but keep in the back of your mind, it does not indicate the overall work of the heart necessarily. If you change blood pressure, you change the work of the heart, and that is not necessarily reflected when you use the index of cardiac output. So just keep in the back of your mind, if blood pressure changes in this situation, that will affect the overall work of the heart in addition to cardiac output. Now we're starting with a normal individual. That red solid line is your reference cardiac function curve, and the blue solid line is your reference vascular function curve. Now suppose we have an acute loss of contractility. The only change we have is a loss of contractility as occurs in the initial stages of low output heart failure. If you simply lose contractility, you would move down vector A. You move from that normal intersection down vector A to a new intersection where you have a cardiac function curve which is shifted to the right. So vector A shows the general consequences of simply losing contractility. Now, if we look at that new intersection point, you have decreased performance of the heart. Cardiac output is down because you've lost contractility, but preload is up. We explained this earlier. If you lose contractility, ejection fraction goes down, and that would tend to increase preload. Now, keep in the back of your mind, there's no heart rate on this graph. But in general, if you move down vector A, cardiac output goes down, blood pressure goes down, and you now function at that new intersection point. But because your blood pressure goes down, you activate the renin-angiotensin-aldosterone system. And we mentioned previously, at least briefly, that if blood pressure goes down, you activate the renin-angiotensin-aldosterone system, and that would increase fluid reabsorption. You increase the volume of the vascular system, and because of that, your vascular function curve shifts to the right. So as that vascular function curve shifts to the right, you move up vector B. And I said, that system keeps retaining fluid until your blood pressure comes back to normal. So when you get to the end of vector B, blood pressure, cardiac output is back to normal, and you stop retaining extra fluid. because performance is back to normal as a consequence of retaining fluid, that is a compensated low output heart failure. So in summary then, if you lose contractility, your cardiac function curve shifts to the right, the renin-angiotensin-aldosterone system keeps retaining fluid until performance goes back to normal at the end of vector B, that is a compensated low output heart failure patient. The retention of fluid, the increase in preload, return performance to normal. Now suppose the disease progresses. If the disease progresses, you continue to lose contractility. And the consequence is we move down vector C. Because you lose contractility, the cardiac function curve shifts further to the right. If you move down vector C, performance goes down, cardiac output goes down, blood pressure goes down, but you have a further increase in preload because ejection fraction goes down even more. So moving down vector C then, the decrease in performance because you lost more contractility is partially compensated by a further increase in preload. But again, because blood pressure goes down, you reactivate further the renin-angiotensin-aldosterone system. And as I said earlier, that system keeps retaining fluid until performance blood pressure comes back to normal. But the point here is the cardiac function curve is so shifted to the right, you develop a plateau phase. No matter how far you move along this curve, performance does not come back to normal. Now, we'll say we move onto the plateau. We'll say we move to the point of the intersection of the three vectors there. We have a huge increase in preload and a significant lowered performance. Now, because the preload goes way up, that will cause pulmonary congestion. Now, how do you relieve that pulmonary congestion specifically? You give a diuretic. If you give a diuretic, you move along to the left on vector E, you move along the plateau. So what is the consequence? You decrease preload, you decrease that pulmonary congestion, but because you're moving along the flat part of the cardiac function curve, no significant decrease in performance. A good clinical book will state, with low output heart failure and pulmonary congestion, you can give a diuretic to relieve that congestion, to decrease preload in the left ventricle, but you don't lose performance as long as you stay on the flat part of the curve. As you move along vector E, you may actually see a slight increase in performance. Now, this is not that difficult to explain. It's because of the Laplace relationship. This is just a small point, but worth mentioning. As you move along vector E, the ventricle is getting smaller, and because of the Laplace relationship, a given increase in force in that muscle mass generates a greater pressure in the ventricle. As the radius of that ventricle decreases, a given force developed by that muscle mass during systole generates a higher pressure in that ventricle. So a decrease in radius alone can increase performance of that ventricle, developing the same active force, but that's just a small point. So moving along the flat part of the curve, you can decrease the preload with no significant change in performance. But that does not result in a significant increase in cardiac output towards normal, does not cause the performance of the ventricle to go back to normal. Vector D represents the consequences of giving digitalis. If you move up vector D, performance returns towards normal. Because you increase contractility, the cardiac function curve shifts to the left. Cardiac output increases, but at the expense of increasing blood pressure, so the overall work of the heart increases. So digitalis, because it increases contractility, it shifts the cardiac function curve to the left, performance returns to normal, cardiac output returns to normal, but at the expense of increasing blood pressure, and the work of the heart increases. If you look at vector F represents a combination of giving diuretics and digitalis. It decreases preload, it relieves pulmonary congestion, but it also increases performance towards normal. Now, if you give a diuretic and relieve the congestion, just giving a diuretic does not increase the longevity of the patient. Giving digitalis returns performance towards normal, but again, it does not increase longevity. If you give a combination of diuretics and digitalis and move along vector F, you decrease preload, you return performance towards normal, but again, you do not increase the lifespan of the individual. Now, the biggest point to understand here is, if you give a combination of diuretics and digitalis, you do move along vector F, performance does return towards normal, but you can also move along vector F by simply giving an ACE inhibitor. The ACE inhibitor acts as a diuretic. It decreases preload, decreases pulmonary congestion. It also returns performance towards normal, not by increasing blood pressure and the work of the heart. It simply increases cardiac output without a significant increase in blood pressure. It may decrease blood pressure slightly as well, but that does increase the longevity of the patient. So in low output heart failure, the standard has been, up to close to the present time, to give an ACE inhibitor. It relieves the preload, relieves the pulmonary congestion. It returns cardiac output to normal, not by a big increase in contractility and an increase in blood pressure. It returns cardiac output to normal without an increase in blood pressure. At the bottom of the page, the text on this page just refers to the material I covered on the previous page in that figure, just in a little bit more detail. Now we finished systolic failure, we want to consider diastolic failure and diastolic dysfunction. Remember, diastolic dysfunction represents a situation where it is difficult for the ventricular myocardium to stretch and receive its venous return. In other words, there's a problem with Frank Starling. This would be due to a decrease in compliance of the ventricle, the muscle becomes stiff, failure to completely relax, as occurs in myocardial ischemia, or in cardiac tamponade, the fluid surrounding the heart prevents diastolic expansion of the ventricle. In all cases, though, you have a preserved ejection fraction. Ejection fraction is normal, but don't forget, ejection fraction is a percentage. Now, in considering the pressure volume loop, what would you expect to see? Now, don't forget, this is a failure. Therefore, systolic performance would go down. Systolic performance is a combination of contractility and Frank Starling. In this case, you're losing Frank Starling. That is the origin of the decrease in performance. And the loss of Frank Starling means the diastolic curve is shifted upward and it has a greater slope to it. Now, just interpreting that shift then, it means at the same end diastolic volume, you have a greater end diastolic pressure. You can't fill the ventricles well during diastole. You begin to lose Frank Starling, and therefore you expect stroke volume to also decrease. So just to summarize this, in diastolic failure, performance goes down. You expect systolic pressure to go down because you're losing Frank Starling. Because you're losing Frank Starling, the diastolic curve is shifted upward. That means at a given end diastolic volume, you have a higher pressure, and because you can't fill the ventricle as easily, stroke volume goes down. Now, in addition, because you have more difficulty in getting blood from the atrium to the ventricles, and this is a big point, atrial contraction becomes more important in filling the ventricle. And because of the stiff ventricle, S4 tends to be accentuated. So very prominent S4 is characteristic of diastolic dysfunction. And eventually, you may get ventricular fibrillation, and you lose that atrial contraction. That further reduces ventricular filling and can precipitate failure. Although in step 1, left heart failure is more important than right heart failure, we do need to mention a couple of aspects of right heart failure. Now, if you remember, the left ventricle is considered more of a pressure pump. The right ventricle is more of a volume pump. It has a very high compliance due to its thin wall and can accept a large volume with only small increases in pressure. The right ventricle can handle an acute increase in volume load, but has difficulty dealing with a pressure load. The right ventricle is very susceptible to increases in afterload, as occurs in pulmonary embolism and pulmonary hypertension. A pressure overload on the right ventricle is not just threatening long-term, it is threatening short-term. However, in most textbooks they will say the main cause of right heart failure is left heart failure. And in left heart failure, don't forget, pressure builds up back through the pulmonary circulation and can cause a pressure overload on the right ventricle. Now, cardiomyopathies are diseases of the myocardium that originate within the muscle itself. Not included in cardiomyopathies are myocardial dysfunctions due to loading conditions, coronary artery disease, or valvular problems. Now, the definition has been extended recently, but basically, cardiomyopathies are problems that originate within the muscle itself. Now, we categorize these based upon the anatomic appearance of the myocardium. We have dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. If we first consider dilated cardiomyopathy, in most cases, the cause is idiopathic, but a number of known causes do exist. In most cases, you have marked enlargement of all four chambers, but it can be limited to either the left side or the right side. Now, the big point here is there's a dilation of the chamber, but wall thickness may be increased, but is not increased appropriately for the dilation of the chamber. Just repeat that. Even though the chamber is dilated and there may be an increase in wall thickness, the increase in wall thickness is not appropriate for the overall dilation of the chamber. In fact, in some cases, there may be actual regions of degeneration along with some hypertrophy. Now, with dilated cardiomyopathy, the main problem is a systolic dysfunction. Therefore, because there is a systolic dysfunction, there's reduced ejection fraction. This is because, again, of a loss of contractility and, in addition, the dilated chamber because of the Laplace effect. Wall tension is proportional to pressure times radius. Dilation increases the radius, which requires a greater wall tension to pressurize that blood in the ventricle. So the combination of a loss of contractility and the Laplace effect then is resulting in decreased performance during systole. Now, there will be compensatory mechanisms similar to what we talked about with the systolic failure. Just assume that compensatory mechanisms are basically the same and treatment is the same for a systolic dysfunction. Now, with hypertrophic cardiomyopathy, there's an inappropriate, abnormally thickening of the ventricular wall. And because of that, the main problem here is a diastolic dysfunction. Not a systolic dysfunction, but a diastolic dysfunction. Therefore, ejection fraction is not depressed, it can actually be above normal. Because of the diastolic dysfunction, you increase back pressure into the pulmonary circulation. That can cause dyspnea and pulmonary congestion, particularly during exercise. Now, in many cases, the hypertrophy is asymmetric with a greater septal involvement. In fact, this hypertrophy of the septum can restrict left ventricular outflow tract, and in this case is referred to as idiopathic hypertrophic subaortic stenosis. And this inappropriate hypertrophy can cause a systolic murmur similar to aortic stenosis, except it's exaggerated by reduced ventricular volume and reduced with an increased ventricular volume, which is opposite to aortic stenosis. The murmur is caused by the close association of the free wall and the septum. If you increase the volume of the ventricle during diastole, it keeps the walls more separated and decreases the intensity of the murmur. But the unique aspect here is you have myocardial fibers showing a pattern of disarray. This indicates it is not a pressure overload causing hypertrophy. If the pressure overload causes hypertrophy, there is no disarray of the fibers. As with other disorders of diastolic dysfunction, you have a prominent S2 and you're subject to atrial fibrillation, which further reduces ventricular filling. And finally, we have restrictive cardiomyopathy. This is the least common of the three types here. This is characterized by a less compliant ventricle, but not necessarily a thickened ventricle. Therefore, the main problem here is a diastolic dysfunction. In most cases, systolic function is normal, therefore ejection fraction is preserved. And it has all the basic characteristics you expect of a diastolic dysfunction, and we've covered those in detail earlier on. Now that you've gone through Chapter 15, you understand the 4 valvular problems in the left heart. You understand mitral stenosis versus mitral insufficiency, aortic stenosis versus aortic insufficiency. You understand the consequences of a pressure overload on the left ventricle causing concentric hypertrophy versus a volume load over in the left ventricle causing eccentric hypertrophy. You also understand which disorders cause a systolic murmur and which disorders cause a diastolic murmur. You also understand that if you get a question in step 1 and they give you the murmur, you start with the murmur. You never start by looking at the size of the atrium, because all 4 disorders can cause an enlargement of the atrium. You go through the answers and you usually eliminate answers that are not possible. You usually end up with 2 answers that are the possibilities. Then you say to yourself, what are the major differences between these 2 possibilities in terms of the information that's given to give you the best answer? And finally, you understand the consequences of an atrial septal defect versus a ventricular septal defect. You know you can identify and separate the 2 by taking blood samples from a Swan-Ganz catheter. We also went through in detail the differences between an atrial and ventricular septal defect versus a patent ductus.